Hi, everybody. Welcome to our GAP MASLD Managed Community Network presentation. My name is Elizabeth Goacher. I'm a physician assistant at the Duke University Medical Clinic in Durham, North Carolina. I've been here for a little bit in hepatology, and I want to talk to you today about MASLD versus MetALD. So before we get too far down the road, if you wouldn't mind using your QR code here to record that you attended this meeting, either in person or virtually when you're watching it on our web pages. So I'll leave that up for a second so you can get a snap of that. I'm going to start with a case. Whenever we talk about MASLD and whenever we talk about patients in general, we like to start cases, right? But I think this is really important when we think about our MASLD, MetALD, or MASLD patients or ALD patients, because really looking at the components of the diagnosis come from the history, which come from our case here. So I want to start with this. This is Ashley, and she's a 52-year-old female who's referred for evaluation in your hepatology or your GI clinic because she had abdominal ultrasound, probably for abdominal pain, maybe because somebody was screening her for MASLD, but maybe not. She has this abnormal ultrasound. It shows the liver is mildly enlarged and increased with hepatic echogenicity, and that is suspicious for cirrhosis, for steatosis. Not cirrhosis, steatosis, and she feels well. But this is a very common person that we're seeing in our GI and hepatology clinics, either for the primary reason of liver disease or for other reasons like abdominal pain, dyspepsia, things that are common to both practices and even primary care. When we think about the information that's important for her. One of the things we think about, of course, is the age, because closer you are to 60, the greater you are for risk for liver disease development, just in general. We look at her medical history for metabolic dysregulation. We think about her PCOS. She has hypertension and hyperlipidemia, so elevated and specifically elevated triglycerides. We look at her physical exam and she looks quite well. She's just smooth, non-tender abdomen with liver edge. Important, guess what, for our talk, because we're talking about metabolic with alcohol-related liver disease, is her alcohol consumption. It's important in any hepatology patient to know. So it's important in GI too. So many places where alcohol consumption impacts gastro and hepatology care. And she drinks about 2 glasses of wine a day. So that means some days one, some days three, but on average two a day over the course of the week. And her common medications, we see atorvastatin, multivitamin, milk thistle, and amlodipine. So if this is our case, and that's our patient, what else do we need to know about her? One of the things we look at is liver enzymes, because abnormal liver enzymes in an ultrasound that shows steatosis obviously raises our concern that we've got more advanced disease. Abnormal liver enzymes pushes that envelope. Normal liver enzymes, people still have advanced disease, but certainly with elevated liver tests, it's more concerning. And we see she's got a BMI of 29, so she's in the overweight, but not yet obese, but almost there by criteria, with otherwise really normal, bland-looking results. Now, the thing I think is important to take away from this is that this is a patient with normal liver test, or excuse me, abnormal liver tests, and we're not going to walk through the diagnosis and the workup for abnormal liver enzymes. Obviously, this lady needs further evaluation for does she have MASLD or not. For the sake of this talk, we're going to presume that's what we're working with, and the adequate evaluation has already taken place. Now, what do we do next? We know she has MASLD. We want to know where she lives in terms of her fibrosis risk. So we get a FibroScan because we have access to that. And our patient had a score of 11.4. And that tells us anybody who's in that 9.6 to 12.5 has a risk for having significant fibrosis. I say risk because when we look at FibroScans, we know there's some elements that can drive scores up that are not from fibrosis, but for the sake of treating patients in our clinics, we have to assume that fibrosis is what's driving her stiffness score at 11.4. So in risk for significant fibrosis, and also we look at her CAP score of 310. So this puts her in having components of increased fat in the liver, severe steatosis, with the presence of significant fibrosis, but probably not cirrhosis at this point. This is where we step back and we look at MetALD, which is metabolic dysfunction plus alcohol-related liver disease, versus MASLD, or just simply MASLD, metabolic dysfunction associated liver disease, or even ALD, alcohol-related liver disease on the far side. So the spectrum of steatotic liver disease includes those components, in addition to making sure that you're dealing with truly steatotic disease, not from other inherited conditions or drug-induced liver injury. There's a rare cryptogenic steatotic liver disease that can't be attributed, but specifically when we're looking at people who are alcohol consumers, So those are over here, and people who have just metabolic dysfunction, and then the people in the middle. So MetALD is the middle of this whole spectrum. So we have people who have metabolic risk factors, but who consume alcohol, and then we put them in the middle. And I think it's important to remember this because this is reflective of our general population. We know lots of people consume alcohol, not just people who are normal body weight and don't have metabolic factors. These are our patients with metabolic risk factors also consuming alcohol. And how do we frame that? And that's what the new nomenclature that came through was helpful in trying to label. It's particularly important when it comes to diagnostic criteria, because that's also what drives our medication and therapeutic choices on the other side. So figuring out where they fall in terms of MetALD versus ALD or just MASLD is helpful. And the thing that's helpful, it is helpful to distinguish, but it's hard to do. This is diagnosis based on, as you can see from this slide, we're looking at self-report of alcohol consumption. So this is self-report of how much alcohol do you consume every day. And sometimes people have a hard time telling us that. Sometimes they have problems remembering that. It's just, especially people who are daily or frequent consumers, it gets really difficult to point out, to say exactly how much they're consuming and what type. But we try and do it by verbal report as best we can, based upon self-report of the different types of beverages they consume and the frequency. In general, all the items depicted here are about 14 grams of alcohol per content of this beverage. So when you look at this, and some people, it's good to have these in clinic so they can pick out what they consume and use pictures if that helps them look at the volume when you're asking, is it 5 ounces or 10 ounces, or how much table wine are you, how much wine are you drinking? How big is your glass? So it's more about looking for how much the quantification is and what are they drinking. Is it highly alcohol concentrated, such as a shot of liquor, or fortified wines or liqueurs like brandy or cognac? Or on the other end of the spectrum, beer, 12 ounces of beer has a lower alcohol content at around 5%. So the amount of alcohol consumed, though, is about 14 grams of each of these beverages, and quantifying that over the course of a day or week helps us in our diagnosis of alcohol-related disease in terms, and also about MetALD versus MASLD predominant. Is an alcohol component present, and to what degree? Why it's important is also based upon the fact that we know, although these different entities, alcohol-induced liver disease and metabolic dysfunctions related steatotic liver disease, have different instant drivers, where they're coming at it is from alcohol consumption or from metabolic derangement that then leads to this downstream effect. These two different triggers still have a similar pathway when it gets down to the deeper level. So what might turn them on is slightly different. They are not the same disease. There are some commonalities in their end results. And this is related a lot to how impaired lipid signaling is happening inside the liver, driven by the different endoplasmic reticulum stresses and oxidative stress and cell death. And then there's also an inflammatory response that's driven by some of these other chain, and this inflammatory response leads to the fibrosis, and it leads to the inability to degrade their fibrosis until it accumulates and accumulates and builds up until you develop the advanced fibrosis. And we know that, like, while it's from two different starting points, that's similar, especially even histologically, it's very difficult to tease apart. Why it's important is because of the overlap. So if you have two different places that both lead to a similar but not exactly the same end pathway, you're going to have, stands to reason you might have acceleration of one or the other. And it's true, surveys have looked at both that alcohol-induced pathogenesis can accelerate in the setting of dysmetabolic factors, and that dysmetabolic factors are accelerated in the setting of alcohol consumption. So looking at both ways, we know there's a synergistic effect, and that's why it's important to treat both components of the disease entity. Looking, of course, for where we can look for dysmetabolic, because the methodology for how we approach pharmacotherapy there is going to be different from the pharmacotherapy we might use for alcohol predominant disease. Stands to reason that when we know alcohol-related liver disease, just a gestalt, we know it's one of the more rapid progressors. This was an analysis that looked at all comers in terms of their rate, modeling out the rate of decompensation based upon their baseline FibroScan scores, and looking also at their MASLD versus MetALD criteria and ALD criteria with the expected nomenclature change, as well as factoring in other drivers that we know that can influence risk factors for fibrosis, so those being obesity, presence or absence of insulin resistance. Other genetic factors, we know there's some genes that are both protective for MASLD-related damage and that are accelerant for MASLD-related damage. So trying to model that also against their amount of alcohol consumption. And as you go from left to right, no shocker here, the further you go in adding more alcohol injury, the greater your rate of decompensation at 5 years. And so we can see that the MASLD, while it's still a progressor, is the slowest progressor, if we will. Then you add MetALD, it accelerates, and then we know ALD being the very rapid, higher rate of decompensation rate over time. So the point being here that while MASLD is still something that causes, and MASH can cause fibrosis over time and rate of decompensation, it's the lowest. And while alcohol is the highest, MetALD is synergistically in the middle. So it's important to make sure we're paying attention and looking for that component so that we can help address it in our therapy. We know that in MetALD, like I was talking earlier, the amount of alcohol that people consume is self-report. And this is something that's in clinic. We're clinicians, we know how to do histories. We try and help people with being transparent and trusting us so that we can get the right answer. But especially when it comes to clinical trials and how you look at therapeutics, how to define alcohol consumption in that trial to help know how much that is impacting the rate, especially in fatty liver disease, what's happening with your patients in their biopsies and their accelerant and their risk factors for progression are challenging. PEth testing is one of the ways that we can look at doing this. That is a tool that can look specifically as it's something that we can look at as a more objective tool and start using those criteria. But currently we're left with these very subjective recall factors. We also know that in a diagnosis of metabolic dysfunction, we can have, if there may be some false positives that we presume are just driven by they're just purely metabolic related when perhaps they may be alcohol driven. And this is particularly true in the case of isolated hypertension or hypertriglyceridemia. We know that we need to look at using these biomarkers to help tease out. Sometimes there's the synergistic effect of the alcohol being driven to some degree, worsening by the metabolic factors and vice versa. So having quantification of these things is going to be more helpful in we're looking at our studies to define what's a good tool to alter them. When it comes down to PEth testing, which is a test, PEth is a biomarker for alcohol degradation. So your PEth level goes up. It's the most, we compare it to having the A1C, right? So A1C goes up as exposure to glucose. It's a representation of glucose exposure. PEth is a representation of alcohol exposure. The more alcohol exposure, the more PEth you make. We can look at our patient, and her PEth test is 120. Now we calculated based upon her 14 grams of alcohol per glass of wine, and she's drinking 2 per day. That puts her roughly, I think the math on my calculator that it was 194, 196, close to 200 grams of alcohol per week. PEth testing puts her at 120, which puts her in the moderate to heavy consumption range. So we know there's a significant amount of alcohol exposure. PEth was detectable for up to 12 days just after a single binge drinking. But also the other thing about PEth testing is that we don't see that there's any significant variability in the results by sex or BMI. Now there's different analysis that need to be done looking at liver disease status that may come to light. But when it comes to BMI, we can use it as a good solid marker and not have to factor in that there might be some variability based upon some other factors that might alter it. We also know that in our overweight people, there's significant alcohol consumption. One of the ways that was looked at was this database of obese individuals in the UCSD database, and it looked carving out trying to diagnose them for MASLD based upon their reported risk factors in their history, and then also looking at their self-reported alcohol consumption. And even in this group, what we saw was 16% of them met the criteria by self-reported alcohol consumption of being MetALD. So if they apply the diagnostic criteria for MASLD, put in the amount of alcohol consumption that people self-reported, 15% of them met the criteria for MetALD. So that tells us it's not a small proportion of people and may have perhaps be underrepresented depending upon how the recall and report of alcohol consumption. So just don't assume. I think the point of this all is don't forget about alcohol consumption in our MASLD patients. Make sure we're trying to put them into the MetALD versus ALD or MASLD based upon self-report and then objective biomarkers if you feel that's helpful and needed. If a person's telling you they're consuming alcohol twice every day, two glasses or wine on average every day, do you really need a PEth testing? Maybe not, but that absolute objective data would be certainly helpful in our clinical trials to help us understand when I'm trying to choose a therapy, how the amount of alcohol might have impacted the results that they're putting forward. So for our patient with hyperlipidemia and hypertension specifically, let's think about alcohol and hypertension. Thinking about, does she really have dyslipidemia, or excuse me, does she really have metabolic derangement or metabolic steatotic liver disease at all, based upon the diagnostic criteria that include both weight and risk factors of hypertension and hyperlipidemia? Might there be other factors? We know alcohol can drive up blood pressure. It may suppress blood pressure initially in the first 12 hours, but after that, there's a rebound effect. So depending upon when this person's blood pressure is being drawn, if they don't have other metabolic risk factors, and this is the only one, are we really looking at somebody who has hypertension as a representation of dysmetabolic or metabolic derangement or metabolic dysfunction, as opposed to an end game from their alcohol consumption? The other thing we can see is triglycerides. If you look at the blue lines in particular, the blue lines with dots and the blue lines with squares, those are the main money points of this one. This is looking at the difference after you expose people who have hypertriglyceridemia or not. So the group that is in the squares on the top line on the right, when you gave them alcohol, even though they didn't have triglyceride elevation at baseline, they did when you gave them alcohol. So exposure to alcohol increases blood pressure, exposure to alcohol increases triglycerides. So looking at that patient you're looking at, we're not saying you need to suspect that they don't have this at the time, but if you look at the big picture, just some little nuggets to go, does this person really have alcohol predominant disease versus not truly meet the metabolic criteria based upon some elements where they don't fully fit? So little things to think about in your history and in your patient, because when it comes down to it, alcohol reduction is still going to be the thing that you want to work with your patients, but how big of a piece of that compared to initiation of targeted metabolic dysfunction associated steatotic liver disease pharmacotherapy going to be a part of your tools. In this patient, actually, so we know she has a KPA that's elevated. She has steatosis on her CAP score with a CAP score of 310. She's got elements that put her at risk for metabolic dysfunction. So to go ahead and call her MASLD predominant, MetALD, is quite reasonable based upon her self-reported alcohol consumption being on the lower end of the spectrum when it comes to the diagnostic criteria. If we had a tool and her PEth testing with that as well. And so does PEth testing help her, perhaps? Is it something you need in this situation? Well, does anybody who has a CAP score of 11.4, which predicts either reversible stiffness, maybe in the setting of alcohol consumption, or true stiffness, fibrotic stiffness, that may or may not be reversible if you treat the injury, they all need to be consuming zero alcohol. At that point, they're at a level where any alcohol is going to be difficult to navigate and put them more at risk for disease progression, whatever the label may be it MetALD, ALD, or MASLD. So what do we do with our patient, Ashley? The same thing we do with everybody. The treatment for MetALD always starts with the treatment of the metabolic dysfunction. This is something we advise all our patients with, whether they have fibrosis or not, whether they have alcohol-induced damage or not, if they are in the metabolic dysfunction category. This person would be a candidate for resmetirom based upon her self-reported alcohol consumption being below or at the threshold where patients were included in the Maestro-NASH trials. So she does have the mild alcohol consumption. Is it really what she says? Perhaps it might be higher depending on the person you're looking at, or if you don't have PEth testing to concord with that. So how you position targeted MASLD pharmacotherapy is going to vary from person to person. But in this situation, she's not an unreasonable candidate for resmetirom. We've already talked a little bit about the importance of alcohol cessation and how she navigates that. And based upon her risk of possibly being advanced fibrosis, should she have HCC screening? In patients who have MASLD and MetALD as well, they both have this potentially greater propensity to develop to develop malignancies, all-cause malignancy. And I think we think about MASLD being a part of we always treat stage 3 fibrosis possibly as stage 4, which the true risk comes in. So not unreasonable to start HCC screening. Data is not firm in this direction. It does seem reasonable and not a bad idea, but also a firm recommendation is really going to boil down to your clinical interpretation of her status and her risk. So we do think about the future for clinical trials for medications that treat MASLD. It'd be great to be able to have some objective biomarkers that help guide us in the clinical trial and design and development so that we know on the outside, on this side, how we apply it in the real world as opposed to that very controlled environment of a clinical trial. And we want to think about making sure that if we have somebody that has elements that might not be purely dysmetabolic risk factors like isolated hypertriglyceridemia, isolated hypertension without any other dysmetabolic factors, making sure we're looking for, are they really a function, just an isolated dysregulation of metabolic dysfunction, or might they be driven by other factors? The other thing I think that is important is we want to make sure we're looking for other risk factors. Is this a static situation? Is this somebody who is an 11.6 kPa and has no new risk factors for exposure, no massive weight gain, no toxicities from certain medications that can cause metabolic in the prior to 6-12 months, and reasonable to reassess over time, but making sure that we're looking for not just this one point in time, but how we deal with how we really give somebody a static diagnosis chronically. We need to look at other factors and how they shape up over time. So we're looking at our diagnosis based upon MetALD with grams of alcohol per week for women and men respectively, as we're represented here, as 140 to 350 grams for women or 210 to 420 grams per men per week. We're looking at how we could we're wondering about whether the biomarkers for alcohol exposure might be helpful. They are in some people, and if you have them as a tool and you talk to your patients about, I'm going to use this test to try and measure your actual alcohol exposure in your system, would that be okay? As opposed to a gotcha moment, important always to do that. If somebody's reporting 0 alcohol and you do a PEth test on them and it's positive, you have not helped them with confronting a liver disease. What you've done is make them not trust you so that they don't give you further honest answers in the future. So making sure you're taking permission to make that assessment. And then looking for all the other drivers of liver disease to see if there's anything that might be driving this dysfunction and this stiffness score that aren't accounted for in your history. So that's the end of my discussion. I hope if there's anybody in the audience that has questions that wants to jump in and have a chat, I'm happy to listen for those. I'll leave this up here for a second so that you can take a snap of our GAP community network for other information about MASLD, MASH, Resdifra, and all different other components of liver disease that we talk about in GAP, as well as GI components.